some projects that have been done. So ECMC, back at the beginning, Karen, can you speak to that project real quick?
We were making a clinical transition from the traditional bed bath, which on one of my nursing units, the nurses loved, versus the transition to the bed in a bag. And they were really struggling with transitioning over to the bed in the bag. So we had the nursing students, the DEU, actually create a presentation on why the bed in the bag was better for the patient and how the nurses had to be the advocate for the bed in the bag. And then my nurses wanted to do a counter, and I'm sorry, they wanted to do their own research on why they felt they should be able to keep the traditional bed bath model. And then we kind of had a duel off between both segments, and Dr. Rhodes was actually the faculty present while each of them presented and then did counterpoint with each other. And at the end, the nurses decided that they would put the bed bath basin in the garbage and that they would try the bed in the bag. Now, traditionally, that's what we do at our hospital. Periodically, we do still have patients that want the traditional bed bath, and we do accommodate for that. But it was a fun way for people to get involved and engaged, to move practice to where it needed to be, and yet it engaged everybody on the unit, and every single person was talking about it. So I would take your DEUs and make them fun. Try to make them the champion of decreasing suffering with infections or improving communication, because look at just the video that we've seen. They're so creative that they bring forth a fresh set of eyes to all of us.
We just wanted to share a couple other ideas that we've had, because you can take these back and look at them in your organizations, whether you're a hospital or any other kind of clinical setting or a faculty person. There was a project that we did at hospice, and Sabrina Schwartz happens to be here, and she was the pivotal in leading the clinical group that worked on this one, improving dyspnea with non-pharmacological interventions in opioid therapy and hospice home care patients. Although we think hospice does a good job with dyspnea and that their HCAHPS will show that, things like that, but there's always room for improvement. And when we went back, the QI person there was so happy to report to me that although they do the presentation to just a small group at the end of the way that we do it our last day, we do our EBP presentations to the DEU nurses and whoever in the hospital or setting will come, in administration, unit managers and things like that, that they actually, their scores improved the next quarter after having information up, and we leave the poster there. The other thing that, although Donna just mentioned, we don't require them to do posters, one of the things that you can think about as an academic setting is, I wrote into our budget that all the senior students last semester have a $40 budget line. And that's part of our DEU project, to do a poster to leave at our clinical sites, so that not only do the people that were at the presentation get the information, but that we have a visible presence on those units too. So that's something to think about. And one of our really recent ones that was just done last spring, and I'm passing around just an example here to show you, and we'll kind of pass it down and around. At Kemmer Mercy Hospital, and two of the people who are on our panel will talk a little bit more about this maybe, but they developed this fantastic evidence-based practice project with the students, also created a PSA. We won't show that because I want to get to the panel, but they were looking at pressure, preventing pressure injuries and nerve damage in the operating room. So you'll see the booklet that they made being passed around. Also in your packets to the left, there was the tool that they found in the literature. So our students were teaching them to use evidence, not to create things just because they made it up. So not another education pamphlet, you know, those kind of things. But what are the tools that are out there that can really improve clinical practice? And so these are great ideas for you to take back to model in your institutions. And if you're leading a program and have anything to do with budget, what can you give back to the units, such as the poster or something that can be left there? Because when people are looking for magnet status, you want to talk about evidence-based practice projects, all of these different things that can help your partners. With that said, I'm going to ask our panel to come up front, and I'm going to introduce everybody, and we'll start out with just general Q&A from the audience, and then of course we have some plant questions that we can ask also. So if Donna gave, oh, here they are. I had to borrow Donna's glasses because I think I left mine at dinner last night when we were at dinner, so please forgive me. But the first person who's going to join our panel that you haven't heard from earlier is Gloria Cockrell. She's one of our recent graduates. She graduated in 2018 from our advanced ABS program. And before she came to us, she was actually in higher education. So she has a unique perspective as a former educator, even though it's not in nursing, and as a new nurse in her transition to practice. And she was working at Catholic Health at Sisters, but I understand she may have a new job now. So her loss may be their loss is someone else's gain. We're sure of that. The other person we have is Kim Dimino, and she comes to us from William Patterson University in New Jersey in 2012 she started there as a pediatric clinical instructor. Kimberly was invited to collaborate with the Academic Practice Partnership to expand a medical surgical DEU to include the pediatric DEU. The MedSurg Pediatric DEU continues to prosper within the William Patterson University program, with Kimberly acting as a pediatric clinical faculty coordinator. Currently, the DEU is not offered to all students, but in efforts to expand the program, Kimberly examined the impact of the DEU on new graduate nurses transition to practice for her doctoral project. Results suggested that the new graduate nurses with the DEU experience during their undergraduate training were overall more prepared for contemporary practice than the others without the experience. In addition, we have Margaret Mayer, who is in a clinical adjunct faculty with us at UB, and she's been at the Kemmer Mercy DEU since last spring, I guess it was. Boy, it seems like longer than that. But as I mentioned that project earlier, Margaret was instrumental in working on that with our students and with the people at Kemmer Mercy Hospital. Margaret is one of only 250 nurse practitioners in the United States who is a dermatology certified nurse practitioner, and she is board certified by the American Association of Nurse Practitioners and the American Nurses Credentialing Center. And so her derm background is very extensive also, but I'm not going to get into that. Let's just say she's an expert. We're happy to have her here for a variety of reasons. Then we have Linda Steeg, who is a full-time faculty member at UB. Linda is one of the 3 DEU pioneers here at the UB School of Nursing and in the Western New York area, working with the DEU model since its inception in 2007. She's taken students to DEUs at ECMC, Buffalo General Hospital, and is currently at the Hospice DEU. And she is celebrating her 20th year here as a faculty member. But in addition, she always likes to tell everybody she's a homegrown tomato because she went to UB from her first degree forward. The next person is Ellen Maurer-Swan, and Ellen is a certified nurse manager who works at Kemmer Mercy Hospital, and she has gained experience through multiple places there in maternity and GYN, med-surg, and as a discharge planning over the past 42 years. She's been in nursing leadership since 1986 and is a previous member and vice president of Western New York AONE, Association of Nurse Executives, right? Is that AONE? I'm saying that right. Thank you. I should know that. And is the current member of the American Association of Critical Care Nurses. She's been a champion for Kemmer Mercy Move with Care program, authored a poster abstract on safe patient handling, a Move with Care program, which was presented at the National Nursing Management Congress Conference in 2017, which she won runner-up for, and published an article on the same topic in Nursing Management Journal. As a nurse leader, she's encouraged professional growth for all associates and participates with clinical education of student nurses. So we see this theme of research and excellence in practice. And then our final panel member is Karen Ziemianski, who is the Senior Vice President of Nursing from ECMC Corporation. She's Buffalo born and raised and has lived here her entire life. From the time Karen was 2, she knew she wanted to be a nurse, and her desire to help others was solidified in her teen years when she volunteered as a candy striper. So you remember candy stripers, so you know, that you really got the in there. Karen graduated from DeVille College as a registered nurse and continued her career in education with support of her family. Karen received her master's from State University of Buffalo in 1988 and joined ECMC in 1995 as a nurse care coordinator. Karen has already explained how she transitioned from those roles to nurse manager to now nurse leader in her institution. She's worked nearly every nursing position there and is a fierce advocate for the patient and for the DEU model. So we thank our panel for being here. But I did want to, before we talk about our questions, because we've had so much information we've shared with you all, open it up, knowing the expertise on our panel or any questions that you may have. Otherwise, I will ask some questions, but we, you know, boy, this is going fast for us, the speakers. I hope it's going fast for all of you. But does anybody in the audience have any questions to this point?
We do have some schools that have traditional model, but we do have the DEU in the in various aspects of our hospital. The binder that went around is our formalized agreement. I mean, we do have a formalized legal agreement with UB, DeUval, Niagara, and many of the, so we do have that, but it doesn't exactly specify right down in the legal agreement about DEU. But I do think having something formalized like the binder that went around is advantageous to both of you, to setting up the rules, the engagement right from the beginning probably is very important. And I think that the unit manager level has to be involved in that, because if they don't understand that, it's not going to be able to flourish on their unit. So I don't know if anybody else wants to speak to that.
Dr. Steeg, just quickly. From an academic perspective, again, when you're talking about this authentic collaboration, it's really important that we constantly understand each other, and the binder provides a hard copy for people to refer back to when there's questions or they're confused or whatever. So it's a great thing.
It very helpful to know what they're studying, what their textbooks are, what kind of content they're learning about in the class itself. And I have to tell you, the model, the concept model is much different than what I did. So it was nice for the nurse to be able to explain it to me and then have it in there so that when I'm talking with her about things in the clinic, she can put it in that concept map and I can understand what she's saying versus why aren't you doing this in ADPI? Right.
I also want to mention, for accreditation purposes, if you're looking at your schools of nursing, they want to know how you interface with the people that act as your preceptors and things like that. So by virtue of having these orientations like we hold, you can say that everybody's received that, or they can't be a DEU nurse. Do they have the paperwork to support that? How do you have those interactions? You have to worry about those types of things when accreditors are looking at you in terms of safety also, but how do you know that people are doing what you say that they're going to do, just like your adjunct faculty, right? So that's an important piece too.
I just wanted to add to that briefly. In the spirit of collaboration with all of our schools, we at ECMC are actually developing a clinical skill template that we will be working with the schools, collaborating with what they're doing in their clinical learning and then application, so that we make sure that we foster their growth while maintaining to our standards for what our expectations of the students in each semester. And then also looking at what the feedback from the schools with their curriculum and where each group is at clinically, so that we can foster those skills and not under or overshoot for where they are, so that they actually are growing in what they're learning in the classroom, on the unit, not only with their clinical instructors from the schools, but then also with our DEU preceptors at the hospital, so that everything is in tandem and we make sure that we cement that foundation of good clinical practice.
I just have a question regarding assigning students to a DEU nurse. So when you have, let's say, 2 nurses on the floor that are the CIs, and you have 6 other students on the floor with a faculty clinical instructor, do you assign those students with the clinical instructor in the same block? Because I'm finding that an issue when I go to clinical. So I'll have like 2 DEU nurses, and there's low census, so I have to spread the wealth in a sense. So not only does the clinical instructor, like myself, have 4 or 5 students, but then I'm putting those students in the block that they also have a student with them. Does that make sense? I'm sorry.
Okay, I'll answer that question. So I have a 38-bed unit, and we have multiple nurses that have been educated as CEIs because they are hearts in it and they're great educators. So we have more CIs than what we really need on any given day. And that's because in addition to the formal education that was provided to them originally, I did ask for UB to come back in and do education for 3 different units so that we were ensured that we would have enough CIs. So on my unit, we have, for UB, I have 2 CIs on the days that they come for 4 students. And then there are an additional 2 other units that get students and CIs. So the instructor circulates through the units. Now for another university, I do have what you're talking about. I have 4 students that are with CIs, and I have 4 students that are with their instructor. And she does not necessarily end up in the same, is that what you're asking, like the same group or the same hallway, or is that what you're asking? She could be anywhere on the unit with the other 4 students.
Right. So when I assign my students their assignment for the day, it'll be in the same block that the nurse has a student nurse. So now the student nurse and the CI are together and caring for like 4 patients, but then one of those patients of the 4 are with myself and the student. So it takes away a patient in a sense from that block.
Oh, no, they aren't assigned the same. They're not assigned patients from the CI. So the CI and the students
Okay.
have a group of patients, and then the traditional students that are with the instructor would have a totally different assignment. They would be in another
they don't
group
overlap
with
at all?
different nurses. No.
Okay.
So this conversation also seems like really an important one, because when we talk about the DEU model, if the importance of having enough CIs for the schools if you're trying to create the model, because when you ask students, were you in a DEU, it kind of makes me laugh a little bit, but not really, because this is a real problem. So you really have a blended unit. It's not a DEU clinical, because part of the role that we really want to emphasize to the clinical partners and for all of you when you talk about your clinical time is that if you're in a DEU, the role of the faculty member there is to help the clinical instructors, meaning the DEU preceptors, and to be that person for the students. So Pam, if it's you, for example, if you're there with the on a DEU, if someone calls in sick, that was supposed to be the CI or the DEU preceptor, then, or something heavy is going on, you help to pick up the patient with the student, not the splitting of your time, because you're really not having that full experience of fostering the development of the DEU preceptor / CI, of working with the challenges with the student, of working on the collaboration and giving back through the evidence-based practice project time. So I think that's something that, to have discussions with the hospital, with whoever, what can we do to increase the number of CIs that are at that place. Number one, doesn't mean having to be over more than one unit, which is what we see with ours at Kenmore Mercy, but those types of things, you know, and the school wants aren't always what the partners can give. So what can we do to make this happen? But to say it's a true DEU, if you're really looking at the model, then your students aren't exactly getting that, because the teacher is back to the 4 that you're assigned outside waiting for you. Oh, Margaret, you want to pass meds? You got to just a minute, because Linda's patient's crashing and I need to be in here with this teachable moment. Right? But we've all been there. So if you're going to do this, you know, that's a piece to it, and that's part of that planning. And what are the needs of the institution that you're partnering with, and what are the needs of the school? So it becomes very important.
Your question's an excellent example that speaks to the flexibility. And sometimes when you're just starting out, the best you're going to be able to do is 2 CIs or 2 DEU nurses. And if you have a group of 8 students, then you may have this, what we call hybrid model for a semester or so. But in the meantime, you're building those relationships. You're also working with the nurse manager and the nurse leadership and say, is there a way I can take my 8 students and I can physically be on 2 units at one time? And so that these students consistently get a DEU model every week.
The 2 CIs that you have on the unit and those students, do those students stay with that CI throughout their entire semester, or do you rotate those extra 4 until you are able to get more CIs? Do you know what I mean?
Again, it's very unique. It depends upon what are the needs of the unit and how long. Are we looking at an entire semester of clinical rotations where there's only going to be 2 nurses consistently every clinical day? Then we may have to do something different if it's just a one-time situation where somebody happens to get sick and isn't there. So it varies. And again, it's very individual.
Yeah. But I can see where it's advantageous to keep the same student with the same CI through the entire thing.
The model is built that way. The model is built for consistency.
So if you needed to, you could instead of just staying focused on that floor, like what Margaret's doing, you could utilize other floors as well.
Yes.
For CIs.
And that's what Margaret and Ellen and Margaret and the other nurse managers are. That's what I'm saying. At that point, you have to go to your nurse leader and say, is there a way we can do this a little differently?
Earlier, you said that in New York State, it's a 1-to-12 ratio for a student.
You have to request that. You have to get a dispensation or whatever.
Okay.
You have to get permission.
Okay. Not being originally from New York, I had searched the whole Board of Nursing Licenses to see what the ratio was. So I was going to ask you, how do you do that on a DEU with 1-to-12?
You don't. This is where you take the faculty, and the faculty is in 2 different places at least.
Okay.
You can't have 12. No, there's not enough beds.
She wouldn't let me come back.
No. That
okay.
When you get your group sizes that big, those people, the clinical faculty person's on 2 units or 3, depending.
Okay.
The students are, again, try and keep the students consistent in those locations with those nurses.
But we use the 1 to 8, even though we have the DEU. So I want to be clear on that. So that's another piece to looking at, what do your stakeholders, your clinical partners say they can help you with, and not overburden their nursing staff, and balancing that with your academic needs. But if you're someone who goes to budget meetings or meets with people that want to know, why do we spend all this money on adjunct faculty, you hear that push for, I thought we went to the DEUs because they could have more students. So I know I'll hear that in budget meetings because they want to see it to the 12. But you have to balance what your clinical partners can give you. So all of our DEUs are a 1 to 8. We did do a 1 to 12 last spring with the person who was our hospice faculty person at that DEU at the time. And at that time, we didn't have the DEU at the VNA. So they had 8 students at hospice and 4 at the VNA. But that's a little bit different. So I can see when we move to all of us, some more community-based clinicals, you may be able to see how when they're asking you to save money, because that's who's asking. It's the academic finance people. Say, why are you doing this? I thought we were going to save money. You have to think about where can you safely do that, because remember, 12 students with preceptors, or DEU CIs, whatever we're going to call them, because everybody does call them different things. We have to remember, was on Donna or Michelle's slide, patient safety always comes first. And that is for the nursing staff on the floor as well as our students and faculty.
I had a question about the joint appointment for the CIs, and I thought that it was mentioned that it's for master's prepared nurses. Do you have a lot of CIs that are master prepared? Is that?
So the joint appointment is for adjunct faculty. So I want to clarify that.
Okay.
So if the one joint appointment that we did have the contract with was for a faculty person, not the CIs, not the CIs.
Okay, thank you.
Can I ask, when you're having people do, the students do experience on the floor and they're doing their evidence-based research projects and that kind of stuff, is that taking off of clinical hour time, or is that a separate day? Are they really having an experience as a nurse would, an 8-hour shift of actually doing patient care?
We've actually had students do it during their clinical time, and they've learned a lot towards clinical.
Oh, I'm sure they do. I just want to know what the ratio is, the amount of days you have that are really clinical-like as opposed to student-like. Like really working as a nurse.
Right.
Thinking
right.
8 hours, 12. I'd love to hear that you put people on off shifts as well.
Yeah, it's just a few hours a semester,
Oh, okay.
and then the rest they do as a group outside of clinical.
Not every day.
So,
Thank you.
So as nurses, of course, we know that there's rotating shifts and nurses working all over like different days of the week. So just curious as to how are you able to manage to get the clinical instructors to be working on that same day? And I know with the pay increase, with extra pay per hour, that is helpful, but are all the hospitals paying all the clinical instructors more to be able to say, I want my Fridays, or want to work on Friday so I can be the clinical instructor for the DEU unit?
Well, we have students on my unit 5 to 6 days a week, and sometimes days and evenings. So the clinical instructors know what days that the students come, and I do the schedule ahead of time for the following month, and the people who want to be CIs need to be agreeable that these are the days that they're going to work. And that does work out well because we have a staff that is so excited to be part of the clinical experience of these nurses, and just the thought that they could be working side by side with them. So it does work out very well. And there's sometimes vacations, or as previously mentioned, that somebody might be sick. But again, we have so many nurses trained to be CIs that we're able to put somebody else in that place. And yes, it's not ideal that they're with somebody different, but it is somebody that's trained to do the job. And we do have so many nurses that do an excellent job at being educators and mentors to these students. Does that answer your question?
It does, thank you.
One of the things we've done also from a model implementation perspective is that, and this comes from the model from Flinders, you can have a primary CI and you pair them up with a secondary CI. So if they're not with one, they're with the other. So you can get some consistency there for the student. And that often addresses a lot of the scheduling issues and the challenges that come with it.
I think the other question that you had that I didn't answer was that are they compensated monetarily? Yes, they are. and that's part of it. But I have to say on my unit that we have such great nurses that are so excited about patient care and really being there, that the comments that they make, like, I never look to see who I'm working with because I enjoy everybody I work with. I think that speaks very highly of them and their ability to work as a team, and this is what the students see. And I think that previously mentioned by Karen is that those students make statements and that they want to work on this particular unit. So I actually had 13 people that wanted 4 jobs last spring. Not a bad thing to have, but I felt so bad about who was I going to give the jobs to.
So it almost sounds like a orientation for new nurses, right? Because you have a preceptor and then a secondary preceptor in case. So
it works out well for when you hire these students that have been part of the DEU on your unit, or if they did their capstone on your unit, they really have a feel and they're like ready to go. They come off of orientation feeling very comfortable about their care that they're going to provide and the team that they're going to work with. Oh, I would have to really figure that out, but I have to tell you that probably at least about half of the RN staff. I have a med-surg unit that has some turnover related to the nursing staff then going to critical care or the ED. So, and then some of them become the stroke advisor. So I do have a lot of professional growth for my unit. My unit is all BSN prepared nurses, 1 master, and only 4 nurses that have associate degrees.
And we'll take some more questions, but first I just wanted to give Kimberly an opportunity because we have her here on our panel. Being from out of the area from New Jersey and having conducted her DNP research on this, if you could share with us anything you've learned from your research or any nuances or differences that you may see from what we're doing here locally and what you're doing in your area.
Thank you. Well, the first one I wanted to say, what just comes, what we were talking about just a second ago, is part of my research was interviewing nurse managers who have hired these DEU students and comparing them to the students who were not from the DEU. They're from traditional clinical units, and they did see that they were much more confident coming in to practice initially. They're more comfortable coming, working with the patients and working amongst the nurses. They did better when they were, during their interviews, they were able to speak to the patient more holistically, specifically speaking about education and cultural aspects of the patient's care, which they don't often hear from a new graduate nurse. And then also that when they were brought into a scenario where they went into a room, because some of the nurse managers take them into a room and say, what's wrong here? And do you see any problems? And they were much quicker to critically think themselves through some challenging situations, much more so than the traditional clinical. So it was some good findings, which I'm able to present at Sigma and the DNP conference and that. So our DEU is similar. We have 8 students to one DEU, and then it's 2 students to each CI. So we have 8 students. We do 8 weeks in a med surg and then 8 weeks in a pediatric. So it's, I think, do you guys have a pediatric specialty for yours as well? Yeah, I think we're the only one in New Jersey who has peds this as a specialty, and we often see the nurses wanting to be peds nurses where they hadn't thought so beforehand, which is very nice for the specialty. Although there's a lot of students who like to be peds nurses, but we've also hired 3 on our unit who are now working as new graduate nurses, and the CIs are so thrilled that they've actually trained them to be their colleague, so they know what to expect and they can train them then even more so. And now we have our DEU students who were hired there and now are our CIs as well. So it's a lovely little environment. We've been there since 2011, so it really does take a village. And they, everyone feels part of that village, including the nursing assistants, the unit clerks. They celebrate their accomplishments. They celebrate their projects. We do the EBP projects. It's very similar to you guys. And the students are able to speak to their experiences in their DEU as well as their QI projects and how they've changed the culture of the unit with them in their interviews. And they've been hired, based on that. Even not necessarily in the institution, but other institutions are impressed by their experiences and ability to have these professional experience as well. One thing we have done is our students, they go to the nurse practice councils at the organizations and they present their projects, which we pushed for, and it works very well. And our next vision is to have the nurses up there with them presenting the projects. So we're working on that. One of the questions I had asked is if all the clinical faculty coordinators are there all the time, because part of the barrier for us to expand is they don't, the organizations don't really understand the model, and they're afraid we're going to leave and exit and not be there for them. And they're worried, you know, as much as we say, no, we're there, they have this impression for some reason that the faculty isn't there enough, and they're not going to be there. So it's helping them to understand the presence and the new role of the clinical faculty for us has been the barrier to expand. So we're looking to really expand, and we need to show outcomes like anything else. And, you know, there's not enough from our side anyway to, you know, encourage the practice side to say, you know, we want you to do this, but what's in it for you? And we can't really put our finger on that enough for that to get a lot of buy-in. Yeah. So that's what we're challenged with. So that's it. Does anyone have any questions for me? No?
And we'll go, I also wanted to we asked Gloria to come, so give Gloria a few minutes to talk and share with everybody here. So as a graduate who has been in a DEU, you can just share with us how you think this has helped you in your practice and how it may be helping you as you move forward in your career.
Thank you. I was very fortunate to be on several different DE units at different facilities even. So that was helpful to just, you know, be exposed to those. But I also had opportunities to be in clinical rotations that did not have a DE unit, and there is a definite difference. So I am all for the DE unit. It's a very positive experience, and it creates a pathway for the student nurse to then get a preceptor position for their senior year on that, you know, same DE unit, and then be employed at that same facility. So that's the pathway that I took. I was on a DE unit, then I had my preceptor at that same facility, and then I was employed at that same facility. So it was very seamless, and I was just more confident going into that facility using their computer programming, their equipment. I was just more comfortable. I knew colleagues when I did get my, you know, my position. I knew colleagues even from other floors. So it wasn't just about my floor, it's about the entire facility. So, you know, the ED, the telemetry unit, like I was, you know, able to communicate with all of them more quickly and more confidently. So I can't say enough about the DEU experience. It definitely just launched me quicker and further. So.
There were a couple other hands that went up in the audience, so can we go back? Thank you.
I just had a question regarding paying the CIs extra money. The hospital I do clinicals at, there's a union involved. So how long do the negotiations take place, and like how did you, I guess, arrange for that to happen? Because I know the union that, because I was part of the same union at one point, it gets ugly.
It didn't get ugly. We were offering extra money and people usually say thank you. So, I mean, it really, at our institution, it really didn't. We really found the value of the CI and the DEU model for many of, you know, for practically 4 hours we've heard how it really sets the stage for the new nurse and to feel comfortable and to have that type of entry into nursing that we would really have loved to have had. So, you know, there's a lot of work that goes into being a true CI. If you're going to embrace the DEU model and really embrace your role, there's a lot of work. I did not have the experience. I've negotiated it I think now 3 times. I never had really a negative experience with that. I don't know if that's atypical or typical, but you know, I did not have a negative experience. I feel it's very value added. I think it's something pro-nursing, and who should really be pro-nursing, but the nursing leaders really should be pro-nursing. So
you said you
Speak to.
you pay your nurses $5 extra an hour, and does anyone else pay their nurses extra money?
It is a union environment, but it's viewed as that this is something that really needs to happen. And it's the same as precepting, really, that people are paid more to precept, people are paid more to be CIs.
Okay, thank you, I appreciate that.
This may sound like a silly question, but when you're looking to establish a DEU in a hospital, I know we're trying to expand our DEUs from Highland Hospital to Strong. What kind of criteria do you kind of establish to pick that one DEU? Just because I understand that you need to have support from managers and administrators, but we're looking at several right now, but a lot of them are having high turnover rates and things of that nature. How are you looking at one specific unit and saying, yes, that unit is going to be the DEU?
So are you starting to pilot the model, or have you have one unit?
Yes.
And now you're looking to expand to a different
Different hospital.
hospital, and you're trying to select the best unit on that hospital, in that
maybe
hospital?
pilot and try to figure out if this, I mean, I guess you kind of answered the question. Do you pilot like a unit and see if it works and then try to, so I'm just curious how that works.
I'll let Karen answer that.
well, I think I would go back to the core reason why. I personally would not choose a high turnover unit because something is going on that unit. I don't know what's going on, but I really would spend the time to try to untangle that. What I would try to do is set the stage for a very stable unit that's going to give the clinical experience that both the university and the service partner want to give. Somebody that's having a high turnover, there's a reason why. They might not have enough hands and feet. They might have negative coworkers. There might be physician bullying. I mean, I could go on and on. Believe me, we've all lived it all, right? So I'm not sure I would introduce what I would feel is that very novice nurse to what is possibly a toxic unit. I would try to 100%, I think you need to address those areas of high turnover to figure out what's happening. So that's almost a separate project that maybe you do involve faculty with. Like, this is an outstanding clinical area that should have a DEU. But my turnover rate is 40%. My manager turnover is 1 every 3 years. And I experience a lot of this and this. Can you help me get this straightened out so that I could have a DEU there? But I would take the opportunity to really look at what's happening on your high turnover and then try to figure out, how do I stabilize it? How do I engage it? How do I change it or transform it so that it could be a DEU? Anybody else?
I just want to add, I think that you need to make sure that you are developing a DEU unit on a unit that the manager is excited about it and engaged, because that's what's going to drive it. If you don't have somebody that's excited at the top, the staff isn't going to be excited. So I think that you have to have a leader that wants that DEU unit, and maybe you start with the CNO and ask them, which unit is this? So that's my advice.
And I'll hand it over to you, Kathy. But when we were picking pilots very early on, one of the things we looked at is, where do we have our strongest traditional relationships? That's a really good place to start. So look at that healthcare system that you're moving into. Where is the traditional model working well? Because that traditional model is working well because underlying that is you already have staff cooperating with the clinical faculty. You already have staff who have bought into supporting those students. That's what made them such positive traditional units. So look there.
Add to that, changing the care in the area. So you said you already have one at Highland. Highland, please go with them to Strong. That, you know, that's one of the things. Yeah, no, but that's one of the key things is, you know, it's one thing for academics to talk about it and how wonderful it is, but to have your other hospital partner there talking about what it does for them, make sure, you know, get them to the meet. If you know each other, even better, but if you don't, make the introductions, because this is that collaborative piece that's really very important.
On our little baby unit, we have the DEU, and we had a turnover last spring quite a bit where we had maturation. We had a big advocate for our A&M, Megan, who had great passion for it, became a manager on the next floor. One of our educators moved up to be an educator. So we were having natural attrition and growth we were happy for, but we had a turnover of brand new CNIs, we call them that. Anyway, student nurse instructors. So having our student nurse instructors come up, we had to teach a whole lot. That was a big challenge. I'm currently trying to get our financial people to give us money for this and help them understand that when they go off shift 2 straight days, there's a cut in pay, which these younger nurses have, you know, big student loans to get rid of. And so if you just speak the language of the learner and the person you're speaking to, it helps. You as a nurse gets it because you're a nurse. When we're speaking to these financial people, they only speak dollars. So I had to just flat out, I'm telling them, this is how many dollars I'm losing in turnover because these guys got to pay off loans. So you got to help me. And that's the angle I'm taking. I don't know if that works with your union, but I imagine those people still have college loans.
And then I was wondering if Margaret and Karen, if you could maybe just tell us, for people who aren't doing bigger DEU projects, kind of the genesis of the project at Kenmore Mercy and how you collaborated on that with the students using what we do with the students who are enrolled in that 475 leadership course too. So just to kind of share, where did this come from and how you worked together and continue to work together as we look to some scholarship related to this and then planning the next DEU project at Kenmore Mercy.
Well, our project was pretty successful last semester. There was some pushback from the students because they had already picked a senior project that they wanted to do based on fall prevention and skin integrity. And I said, why don't we do something that really is going to make a difference? And they said, no, we already have this picked out. We want to do this. And I said, this is a big, issue, but this has been done before. So let's do something different and something that will make a difference for the hospital that we're at. So I got the students involved with the operating room educator and the director. And Ellen helped coordinate that for me. She's on a different floor, on a med-surg floor, which is a stroke floor also. And it took a little bit of push, but when it came through, it was just beautiful. The project was so well appreciated and the students felt really good about what they had done instead of just doing something that was status quo, because it was so meaningful. And at our research day, people stood up and they said that this information was so valid and needed to be disseminated to all the hospitals in the country. And so it was a very meaningful thing. And the students then understood why I wanted them to do something that would help the hospital and that we are their partners and they help us, so we need to help them.
You want to describe the project?
The project was related to pressure injury and nerve damage in the OR. So we connected Margaret with the clinical advisor in the OR, Ellen Colin, and she and the students worked together to take pictures. So the students were actually the actor patients, and they laid on the tables and Ellen took the pictures, and they actually put together a poster that was so professionally done and a binder that when we presented this at our Nurses Week, as all the posters that were made throughout the year by our nurses and by the students, the books were out on the table. The nurses from those surgical units looked through the books and said, we need these on our unit. They would really be helpful. So I had our administrative secretary make copies of the books for those units. So they presented as though they were professionals. They stood up at Kemmer Mercy at our committee day, which is our shared governance, and there were over 50 people in the room. These 8 students stood up there with their poster and they just talked about their whole research on it and how they did it, and it was just unbelievable because everybody in the room was just so in awe that these students did this elaborate project. So it is an example of how the students do give back to an organization and are able to work with the organization on doing such a great project. So I think, am I allowed to say that we're going to work with UB to get this published? So it's so exciting. I'm allowed to say that?
So we talk about different ways to look for faculty scholarship are really important too. So we're reaching noon. Is there any other big questions?
A preceptor who's perhaps a little bit less interested in precepting. I'm just thinking some of the NP students. Is there support? And as this presentation is going on, I'm thinking, the DEU is kind of like consolidation, what we used to call consolidation ahead of time, because this is the support of the nurse as well as the instructor. So they kind of get a 2-for-1 very early in their career, which permits them to be more expert as they come to the end of the program. And then up in Ontario, we're hearing from the RNAO, post fellowships to improve practice for, whatever your clinical interest is. Perhaps, pain comes to mind. And I had an NP who came and did some time with the acute pain service to increase her knowledge about that. So I'm just interested, I'm interested in geriatrics and I work in primary care now, but how would that DEU model look for those of you who have kind of laid the path?
One of the things about advanced practice nursing is the availability. So could the model be used in that way? It certainly could, but when you talk about your NPs going to clinical, I think we're seeing a lot of movement more towards residency programs being the next step in NP education, as opposed to DEUs themselves. One of the SUNY schools, and I can't remember if it's Upstate or Stony Brook, is doing a residency program with their family nurse practitioner students, and that's something that's brand new. But when you think about if you have existing relationships with a big hospital system or a clinic, you don't typically have one-on-one faculty person there with your advanced practice nurses. You're hooked with the preceptor, and then you get 1 or 2 site visits from the faculty from the college. So man hours wise, I'm not sure the DEU fits when you talk about an advanced practice nurse being in clinical with 8 students at however many clinical, you'd have to have 8 students, 6 or 8, it depends, with you at the same place to foster that development. I don't want to sound negative about it. I just think that the potential is there, but trying to find a space for that many students, the residency program approach seems to be the way places are going.
I was kind of thinking the opposite way to bring the NP student to a place where there's some excellence related to a specialty. So I've done some recent work with neuropsychology, and I'm just thinking about our dementia patients and how, we as NPs, we encounter these patients, but do we have the expertise to look after them? And how do we gain that expertise, seeing them both clinically as well as having, the basic knowledge about all the different types of dementia and the complexity of looking after those patients in the community, right? So they were kind of my thoughts that kind of made me curious to come today.
Well, thank you. And I think those residency programs, though, when you talk about specialty residencies, seem to be the direction we're seeing, is one of just the comment that.
Residency models are
more or less built on the DEU model, where you have the advanced practice nurse student working with a preceptor.
And the expense of those residency models, like what does that look like? Because I don't have them in the province of Ontario. I've heard of them here. And, you know, when I did some time in North Carolina, I heard of them there as well. So how does that work with the university and the, is it an extra expense to the student, or does it extend
we
their
aren't
program?
currently doing them, but I probably could hook you with somebody through SUNY. So if we just make sure your email's here on the list. So
It is, thank
I'll make
you.
sure I'll connect you with someone who may have better information. But I do know that the one that I just learned about through SUNY was grant funded. So they wrote a grant for it. So I think you have to look towards some grant funding. And I have to say that the NP practice model was around before the DEU model. So yeah, so it's a little bit and the flip that this is how we've done it. But this move towards like medical residency programs, we see them with students even when they graduate from our RN programs. Sorry, from like what program am I talking? The RN programs. So certain opportunities, but I think that might be a good connection, and maybe I can help you make some connections.
Thank you.
I just wanted to add the importance of the manager in this whole role. I meet with the students the very first day that they're here and towards the beginning of their time, so that I can go over how excited that we are to be part of their clinical training. And then I go over a little bit about the unit, a little bit about the staff, and I always go over what quality improvements we're working on. So like Donna earlier said, it's so important that they know what things you're working on so they can be part of that and be helpful, like the falls prevention or rounding. So if you want the students to do something, you have to be sure that you include that in their orientation on their very first day. And they're so excited. One of my meetings with the students, I thought, oh, this is going to be a half hour or less. It ended up being more than an hour because they have such great questions about transformation leadership and just everything. So I think that they're going to be as excited about nursing as the instructor is and as the staff and the manager are. So that's my advice.
As Linda reminded you, we will be sending the evaluation for your continuing nursing education credits. So please answer that. And we will probably also be sending a kind of a Google form evaluation specific from the UB School of Nursing too, about what you gained from this experience. So thank you to everybody. You have the UB's contact information. If you have any questions, please don't hesitate to reach out to us. It's great to meet everyone, and hopefully we'll have some collaborations based on today. Thank you.